Okay, let's dive in. Imagine the situation, maybe for your exams or just understanding critical care. Your heart's trying its best, beating away, but it feels like it's trapped, like it's in a box that's getting smaller and smaller.
That's a pretty good analogy. That's essentially the crisis in cardiac tamponade, and yeah, it demands really immediate attention.
Right. So cardiac tamponade, it's a medical emergency, isn't it? Where fluid or blood builds up around the heart.
Exactly. And the pericardial sac, that's the sac around the heart.
Yeah.
And this buildup just squeezes the heart, stopping it from pumping blood like it should.
And today we're doing a deep dive on this. We want to cover what it is, what causes it, who's most at risk,
Oh.
how it actually affects the body's physiology, and crucially, how we spot it and what we do about it. It's vital knowledge.
Absolutely vital, because getting this diagnosis quickly, well, it can literally be life or death. Okay, so let's break it down. At its core, what is cardiac tamponade?
Okay, so think of the heart inside that double-layered sac, the pericardium. In tamponade, something fills the space between those layers. Like what kind of stuff?
It could be blood, other fluids, pus from an infection, even blood clots, or very rarely gas.
Wow, okay.
And all that stuff building up increases the pressure inside the sac. This pressure then, well, it crushes the heart chambers.
Which means they can't fill up with blood properly.
Precisely.
Yeah.
Especially the ventricles during diastole, their filling phase. And if they can't fill properly, they can't pump enough blood out.
Leading to serious problems.
Yeah, in serious cases, we call it haemodynamic compromise. It's a critical drop in the heart's ability to circulate blood. Reduced ventricular filling is the key issue, and yeah, that's why it's so dangerous.
Got it. So what are the typical things, the scenarios that lead to this kind of pressure buildup? What are the causes we need to know?
Well, the causes are quite varied, but they often fall into a few main categories. Trauma to the chest is actually the most common cause.
Really? More common than, say, heart issues?
Surprisingly, yes. Things like motor vehicle accidents or, penetrating injuries like stab wounds.
Okay. Trauma first. What else?
Then there's pericarditis, that's inflammation of the sac itself. This includes something called Dressler's syndrome, which can happen after a heart attack. It's like an immune reaction.
Right. Inflammation. That
Yeah.
makes sense. Injury and inflammation. Are there other big categories?
Definitely. Malignancies are a big one, especially cancers like breast and lung cancer that might spread to the pericardium.
Okay.
Infections, too viral, bacterial, even fungal infections can lead to fluid buildup.
Right.
And then you have connective tissue diseases, think lupus, rheumatoid arthritis, that sort of thing.
Oh, quite a range.
It is. We also see it sometimes after radiation therapy to the chest or in severe hypothyroidism, that's myxoedema, and also with chronic kidney disease.
Hmm.
Plus, bleeding after heart surgery is a known risk. And sometimes we investigate thoroughly, and we just can't pinpoint a specific cause. That's what we call idiopathic tamponade.
That must be frustrating. Are there any, like, less common or maybe unexpected causes to keep on the radar?
Yes, a few more. Certain drugs have been implicated, things like hydralazine, isoniazid, minoxidil. Procedures that involve instruments near the heart carry a risk of accidental perforation. And air getting into the sac pneumopericardium can cause it too, sometimes from mechanical ventilation or a rare connection, a fistula.
Air. How does that happen?
It's uncommon, but yeah, air can build up pressure too. And one really critical cause we absolutely must mention is aortic dissection.
Ah, the tear in the aorta.
Exactly. If that tears near the heart, blood can rapidly fill the pericardial sac. It's often catastrophic.
Okay, that's a comprehensive list of causes. So, thinking about all those triggers, who should we consider most at risk?
Well, the risk factors basically mirror the causes we just discussed. So naturally, anyone who's suffered significant chest trauma,
Makes sense.
people who've recently had heart surgery or invasive cardiac procedures, patients with a history of pericarditis or other inflammatory heart conditions,
Oh, yeah.
those with known cancers, particularly the ones we mentioned, individuals with connective tissue disorders, and also patients with certain infections, particularly TB and HIV.
Okay, so it ties back directly to those underlying conditions. Now let's get into the mechanics. How does this fluid buildup actually, mess things up physiologically? Walk us through it.
Sure. It's a cascade effect, really. First, you get that fluid or blood accumulating in the pericardial space.
Step one.
Step two, this increases the pressure inside that sacration. The intrapericardial pressure rises.
Okay.
Step three, that rising external pressure starts to squeeze the heart chambers, especially the relatively thin-walled ventricle.
Compressing them.
Exactly. Step four, This compression limits how much the ventricles can relax and fill with blood during diastole.
So less blood gets in.
Right, which leads to step 5. Because less blood filled the ventricle, less blood gets pumped out with each heartbeat. That's your reduced cardiac output.
And that's the hemodynamic compromise you mentioned earlier.
That's it. The heart just can't keep up with the body's demands because it's being physically restricted.
Okay, that clarifies the how. Now, because the symptoms can be quite dramatic, but maybe nonspecific sometimes, differentiating it is crucial. What else could look like cardiac tamponade? What's on the differential diagnosis list?
Yeah, absolutely critical point for diagnosis.
Yeah.
You need to consider aortic dissection itself. As we mentioned, it's a cause, but also a differential. Cardiogenic shock, where the heart muscle itself is failing badly.
Right.
Constrictive pericarditis, that's different. It's more chronic scarring and stiffening of the pericardium, not usually acute fluid.
Okay, so constriction versus acute compression.
Precisely. Pulmonary embolism, a large clot in the lungs, can cause right heart strain and shock. Right ventricular infarction or failure could also mimic it.
So other heart and lung emergencies.
Yes, and even severe respiratory problems like acute asthma or a large pleural effusion fluid around the lung or tension pneumothorax, which is trapped air collapsing a lung and shifting things in the chest.
Lots to rule out.
One more, rarer one, particularly in infants on ventilators but possible otherwise, is tension pneumopericardium. That's air under pressure in the pericardial sac itself.
Right, the air you mentioned earlier causing pressure. Okay. Thankfully, you said it's rare overall. What are the numbers like?
Yeah, definitely considered rare. Estimates in the U.S. put it around 2 cases per 10,000 people.
Okay, not common.
No. And interestingly, the causes tend to vary by age. You see trauma and maybe HIV-related causes more in younger adults.
Right.
Whereas malignancy and chronic kidney disease become more frequent underlying causes in older individuals.
That makes sense. Okay, clinical presentation. What are the signs and symptoms we should be looking for? What makes you suspect tamponade?
It can present differently depending on how fast the fluid builds up. If it's slower, more subacute.
Like over days or weeks?
Yeah, exactly. Then the symptoms might be more gradual, maybe anxiety, fatigue, some swelling in the legs or abdomen, maybe confusion in the elderly.
Subtle onset.
Can be, but if it's more acute, happening quickly.
Like after trauma or dissection?
Yes. Then you'll often see severe shortness of breath, dyspnea, a really fast heart rate, tachycardia, fast breathing, tachypnea. Their hands and feet might feel cold and clammy because the circulation is poor.
Okay, more dramatic picture.
Definitely. And you should also look for any signs suggesting the underlying cause, like chest pain typical of pericarditis, if that's the trigger.
And isn't there a classic triad of signs associated with tamponade? Beck's triad?
Yes, Beck's triad. It's important to know for exams, but honestly, you rarely see all 3 together, especially early on. It's more of a late finding.
Okay, good caveat. What are the 3 signs?
It's hypotension, so low blood pressure, muffled or distant heart sounds when you listen with a stethoscope, and distended neck veins, JVD, jugular venous dissension because the pressure's backing up.
Low BP, quiet heart, full neck veins. Got it. What other clues might we see on examination?
Well, besides the fast heart rate and breathing we mentioned, you might find an enlarged liver, hepatomegaly, again from that backed up pressure. Sometimes you might hear a pericardial friction rub, that kind of scratchy sound, if there's also inflammation.
Okay. And what about that specific blood pressure change with breathing? Pulsus paradoxus. It's pulsus paradoxus, exactly. It's an abnormally large drop in systolic blood pressure, typically defined as more than 10 millimeters of mercury during inspiration when you breathe in.
Why does that happen?
It's complex, but basically when you inhale, more blood returns to the right side of the heart. In tamponade, the squeezed right ventricle bulges into the left ventricle, reducing its filling and output even further during inspiration, hence the bigger pressure drop.
Okay, that makes sense. And you mentioned the neck veins, the JVP. Is there a specific finding there?
Yes, this is a key one, especially for differentiating from other conditions. In tamponade, the normal Y descent in the JVP waveform, which represents ventricular filling, is often diminished or completely absent.
Absent Y descent. Correct. Because the high pressure in the pericardium prevents that passive filling from the atrium to the ventricle. There's a useful mnemonic. Tamponade, Campax.
Campax.
Yeah, Tampax, no Y descent. Helps you remember for exams.
Huh. Okay, I won't forget that. Tamponade, Tampax, no Y. Brilliant. Any other potential signs?
In very severe late-stage cases, you might see cyanosis, that bluish tinge to the skin from low oxygen, and possibly even signs of pulmonary edema fluid backing up into the lungs.
Okay, serious signs. You mentioned differentiating it from constrictive pericarditis earlier. That absent Y descent is one difference. Are there other key points comparing the two?
Yes, it's a really important comparison, especially clinically. Let's summarize the key differences.
Okay.
JVP. Tamponade typically has that absent Y descent. Constrictive pericarditis usually has prominent X and Y descents.
Got it. Y descent gone in tamponade, present in constriction.
Pulsus paradoxus.
Right.
Usually present in tamponade, typically absent in constrictive pericarditis. Kussmaul's sign. That's where the JVP paradoxically rises during inspiration. That's rare in tamponade, but often present in constrictive pericarditis.
Opposite of pulsus paradoxus effect on JVP.
Kind of, yeah. And finally, a characteristic feature sometimes seen on imaging in constrictive pericarditis is pericardial calcification, like scarring. That's not a feature of acute tamponade.
That's a super helpful comparison table in my head now. Okay, so we suspect tamponade based on history and examination. What investigations do we order to confirm it?
All right, investigations. You start with blood tests, but they're more aimed at finding the underlying cause. So things like cardiac enzymes, CKMB, troponin, kidney function tests, a full blood count.
Standard workup.
Yeah, and maybe markers for inflammation or autoimmune disease like ESR, CRP, ANA, rheumatoid factors if you suspect those. Tests for infections like HIV or TB might be relevant depending on the context.
Okay, blood's for the cause. What about imaging or heart tests?
ECG is essential. It can show some suggestive changes like low-voltage QRS complexes or electrical alternans, but these aren't always present or specific.
Right.
A chest x-ray might show an enlarged cardiac silhouette, sometimes described as a water bottle shape if the effusion is large and chronic, but it can look normal in acute cases?
So maybe helpful, maybe not.
Exactly. The really crucial investigation, pretty much the gold standard for diagnosis, is a transthoracic echocardiogram.
The heart ultrasound.
Yes. Echo is fantastic. It can directly visualize the pericardial fluid, estimate its size, and crucially, show signs of haemodynamic compromise, like diastolic collapse of the right ventricle or right atrium.
So echo is key. Anything else?
MRI or CT scans can also show the effusion and provide more detail about the pericardium or surrounding structures, maybe helping identify the cause like a tumor or dissection, but they usually take longer than an echo.
Right, echo is quicker bedside usually.
Often, yes. In some complex cases, invasive monitoring with a Swan-Ganz catheter might be used to measure pressures inside the heart directly, and procedures like pericardiocentesis or getting pericardial biopsy are sometimes needed for both diagnosis analyzing the fluid and treatment. Okay, so echo is the main diagnostic tool, backed up by other tests as needed. Let's move to management. We've confirmed cardiac tamponade. What happens next? It sounds urgent.
It is urgent. Immediate intervention is the priority. The definitive treatment is almost always aimed at removing that fluid or blood from the pericardial sac to relieve the pressure.
How do you do that?
The main procedure is pericardiocentesis. That involves inserting a needle, usually guided by ultrasound, into the pericardial space and draining the fluid.
Okay, needle drainage.
Yes. In some situations, particularly if the fluid is very thick, like clotted blood, or if it keeps coming back, surgery might be needed. This could be creating a pericardial window, a small opening for ongoing drainage, or more extensive surgical drainage.
And I assume treating the underlying cause is important too.
Absolutely essential. Draining the fluid fixes the immediate emergency, but you have to address why it built up in the first place. Treat the infection, manage the cancer, control the inflammation, repair the trauma, etc.
Makes sense. What are the very first steps, say, in the emergency department or ICU when you suspect tamponade?
Okay, initial management. First, think ABC's airway, breathing, circulation. Secure the airway if needed. Give supplemental oxygen.
Standard resuscitation.
Yes. Now, circulation is key here. While we're often cautious with fluids in heart failure, in tamponade, giving small, careful boluses of intravenous fluids can sometimes help maintain blood pressure temporarily by increasing filling pressures.
Oh, interesting. Fluids can help here.
Yes, cautiously. Especially if the tamponade is due to trauma and blood loss, then blood transfusion is critical. Elevating the patient's legs can also help venous return.
Okay. Any medications?
Positive inotropes drugs that make the heart contract more strongly, like dobutamine, might be considered to try and boost output, but they're often not very effective if the heart is physically compressed. The main issue isn't contractility, it's filling.
Right. The compression is the problem.
Exactly. And a really important point. Try to avoid positive pressure ventilation like intubation and mechanical ventilation if possible.
Why is that?
because the positive pressure in the chest can further reduce the amount of blood returning to the heart, worsening the situation in tamponade. Obviously, if the patient needs intubation for airway or breathing failure, you do it, but it's something to be aware of.
Okay, so support ABCs, give cautious fluids blood, maybe inotropes, avoid positive pressure if feasible, and get ready for drainage.
That's the initial plan, then move towards definitive treatment.
What does that involve more specifically?
As we said, echocardiogram-guided pericardiocentesis is often the definitive first-line treatment. Doing it under echo guidance makes it much safer and more effective.
Right, see where the needle is going.
Precisely. Sometimes, especially in an emergency, a blind subxiphoid approach from below the sternum might be done, but echo-guided is preferred. Another less common option is percutaneous balloon pericardiotomy, creating a hole with a balloon.
Okay, and what if the fluid keeps coming back? What are the surgical or longer-term options?
Right, for recurrent effusions, especially malignant ones, surgery is often considered. Options include pericardiodesis, where you instill a substance like doxycycline or talc into the sac to make the layers stick together and prevent fluid reaccumulating.
Sclerosing this space.
Exactly. A pericardioperitoneal shunt can be created to drain fluid from the pericardial sac into the abdominal cavity, particularly for cancer-related effusions. And in very rare refractory cases, the entire pericardium might be surgically removed to pericardiectomy.
Wow, removing the whole sac.
Yeah, it's a major operation, reserved for specific situations, more common in constrictive pericarditis, actually. One important note is that sometimes, especially with smaller effusions but significant physiological impact, maybe from malignancy or autoimmune disease, the response to simple pericardiocentesis might be poor because there's an element of constriction too.
Ah, so it can be complex.
It can be. And again, just to reiterate, avoid positive pressure ventilation if you can, and always prefer echo guidance for procedures.
Understood. So assuming timely and appropriate treatment, what's the outlook? What's the prognosis for someone with cardiac tamponade?
It really depends heavily on a few factors: how quickly it was diagnosed and treated, and crucially, what the underlying cause is.
Cause matters a lot.
Immensely. Tamponade, due to trauma that's quickly drained, might have a good outcome if the injury is survivable. Tamponade, due to widespread metastatic cancer, unfortunately, carries a much poorer prognosis, even if the immediate tamponade is relieved. But the key message is that early recognition and prompt treatment are absolutely vital to reducing mortality and morbidity. Speed is critical.
Speed saves lives here. What are the potential complications if things aren't managed quickly or effectively?
Well, the most severe complication is, of course, cardiac arrest and death due to the complete failure of circulation. Short of that, profound shock leading to organ damage, kidney failure, liver failure, brain injury from lack of oxygen. The tamponade can also recur if the underlying cause isn't dealt with or the drainage isn't complete. And then you have all the potential complications related to the underlying disease itself, like the progression of cancer or complications of autoimmune disease or infection.
So a really serious condition with potentially devastating outcomes if missed or delayed.
Absolutely. High index of suspicion is key.
Okay, this has been an incredibly valuable deep dive. Let's do a quick recap of the absolute must-know points, especially for anyone revising for exams like the MSRA Cardiac Tamponade. It's a critical emergency.
Caused by fluid or blood accumulating in the pericardial sac, compressing the heart.
Preventing it from filling and pumping properly. Diagnosis relies heavily on clinical suspicion and, crucially, echocardiography.
And treatment is urgent drainage, usually via pericardiocentesis, alongside managing the underlying cause.
And don't forget Beck's triad hypotension, muffled heart sounds, distended neck veins, though it's often late, and that key JVP finding.
Tamponade, Tampax, absent Y descent. A great high-yield point.
Definitely one to remember. Fantastic. For more high-yield revisions just like this, designed to help you ace the MSRA, you should definitely head over to passthemsra.com and also check out freemsra.com for, well, free resources.
Keep diving deep into your learning, everyone.